Okay. Is this fine?
Yes.
Great. Okay, so we can start finally. So I'll try to share with you some of our experience on the Israeli COVID the vaccine rollout experience. And I'll start with just a little bit of where we are and where did we start with the vaccine. So these are the three actually surges that we had in Israel. The first one, a very small one, starting on March 2020. Then we had a second, much larger one in June, July it started. And eventually the largest surge was started just at the time that, or just maybe 2 weeks before, we had the rollout of the vaccine started. And in Israel, we had only one vaccine, which makes it very interesting and on another hand, maybe easier to introduce. And that's the Pfizer vaccine. So it's easy that we don't have, a lot of debate on which is a better vaccine and all of that. Everybody gets just the Pfizer vaccine. That's what we have in Israel. And the other fact that I think helped a lot is the fact that we were just starting this very large surge, as you can see, and people started to be afraid of what's going to happen. There's a lot of death also. And I think that's one of the things that definitely assisted in the fact that we had a successful vaccination rollout, which I'll show in a minute. And if we look at, and this is a relatively old from somewhere in February, but you can see that Israel vaccination rollout was much, much more successful than many other countries, including the UK, United States, and others. And this is still so. We have, and I think I have a more, and this is actually even not so much updated, but it's pretty much. We have by now 92% of people age over 70, actually it's even slightly more than that, are vaccinated. And about 90% of people over the age of 50 are all vaccinated. We just started a few weeks ago vaccination of youth age 12 to 16. And there right now we still have only about 4%. And vaccination of youth started after actually the surge was down. And maybe that's one of the reasons that people didn't really go rapidly to get their children vaccinated. But I think right now it might be changing because just in the last few days, we have a few cases of incoming people with the Delta variant, the what we call the Indian variant. And that also seems to be, again, putting some alert, and people, I think, will start getting vaccinated also for the children at that age group. So what were the keys to success of the Israeli vaccine rollout? And I think we had several things. One is the Israelis. Well, I guess the first one I actually said is the fact that the surge was so high and was during the time that we just implemented the vaccine, introduced the vaccine. A second is the Israelis' healthcare system, which I'll say a word or two about. Another fact, and I mentioned it maybe slightly, is the fact that Israel was in a way like the Pfizer's real-world experiment. And there was a lot of debate on that. People initially were angry. Are we, the animals of the world to be in a study? I think actually that this is really, we were lucky to be a country which succeeded to get so many vaccines. And I heard the Pfizer CEO say that, they really had a dilemma because on one hand, they want to distribute, as many vaccines to everywhere, not just a single country, of course. But on the other hand, they did want to see what happens when a single country really gets vaccinated well. When do we get to the herd effect and all of that? And for that, they chose a small country like Israel. We have 9 million citizens in Israel. And a country where they thought has a well-developed healthcare system that will be able to really distribute the vaccines well. And I think that was really successful indeed. Another thing I think helped was the fact that we had a rather low vaccine opponents, the proportion of them. While they are voicey, they do, have a lot of on Facebook, on Instagram, and all of the websites, etc. But they are not such a large proportion. I think that was also successful. And maybe the last but not the least important key was the fact that I think in Israel we have high emergency preparedness. And once people said, now we have this pandemic, this is the current war that we have to face, everybody was there to try and help to get us out of it. Everybody puts his maximum effort. And in that way, I think was one of the other keys for this success. Now, about Israel's healthcare system, just one slide to mention. So we have a national health insurance law. Every legal resident receives all the medical care with very low co-payment, and that, of course, included the vaccines. Medical coverage is universal, independent of the employment status, the place of residence, or tax payment. And there are 4 public sector healthcare funds, HMOs, and they provide the community-based medical services. And they're all fully digital, electronic medical record system. And that was all, I think, very, very helpful. So people could nearly get the vaccine whenever they just wanted and wherever they wanted. If they were healthcare workers, they could get it at the hospital or out in the community. Whatever was closest, whenever you come, you can get it. Everything was made really feasible. And I think that was one of the keys of success. Another thing was the prioritization. The prioritization went gradually, but very rapidly, with initially starting with healthcare workers and with them together, long-term care facility residents and staff, anybody age of over 60, anybody with severe immunocompromised situations, also chronic lung, low pulmonary reserve, caregivers to older people, even if they were not in long-term care residents, prisoners and prison guards were also in the first tier. Then very rapidly, we moved on and added risk groups like diabetes, obesity, and then started going down with the age gradually. Initially, it was everybody from age, as I said, 60, then rapidly we moved to 50, 45, 40, and eventually everybody could get it, including today. And just a few weeks ago, we started also vaccinated, as I said, children or youth age 12 to 16. And as I mentioned this, there was a lot of debate on this. How is it that Israel moves to the head of the vaccine queue? Is this fair to the world? What about equity? How do we distribute the vaccine? And in Israel, what is Israelis MOH offering to Pfizer that they agree to give us all the vaccine? Is there something, and a lot of conspiration theories, and what is this? What kind of data is Israel going to give Pfizer? Is it all going to be anonymous? I don't want my data in Pfizer's database, etc., etc. But I think we eventually did manage. Again, I was very much pro this. I think that if one country can teach all other countries something and we can learn from something, I'm very happy to share it. And I'm very happy that we did achieve these agreements. And I think eventually, obviously for Israel, it did prove right. And I think and I hope that we can also show something to the world regarding, when you get to herd effect, who is more important to vaccinate, and all of those questions. And I'll try to show a little bit of what we've been learning. So very early on, we started having data from Israel. Actually, our short letter in the Lancet was one of the first, or maybe even the first, to show that the vaccine is effective, to talk about the effectiveness of the vaccine. But very rapidly, there were many more important, additional important studies, like the New England paper of Dagan et al. On the nationwide mass vaccination, and then these other papers on the national immunization by the MOH and others. And I will not be able, of course, to give all of the data, but I definitely recommend these papers. I think they're very good. I'll try to give a few words on some of these and to walk you through what we know by now from Israel. So Sheba Medical Center, where I work, is the largest tertiary medical center in Israel. And as I'll show in a minute, we had a very successful campaign and rollout. And we very rapidly understood that we need a follow-up. This is a new vaccine. We have to monitor and we have to see what happens with people who are exposed. We need to check what is the vaccine effectiveness in the real world. It's really nice to have all the data from clinical trials, but as we know, a clinical trial is not always the same as the real world data, and we wanted to compare that. We wanted also to know what's happening with symptomatic and also asymptomatic infections, and last, what about immunogenicity in the real world? How many antibodies are developed? For how long will this maintain? And all of those questions. Okay, and so the first study is the study on vaccine effectiveness, and our aim there, it was very rapidly, we started with this within 4 weeks after the first dose of the Pfizer vaccine. The Pfizer vaccine is given, I'm not sure what is given in Colombia, so I'll just mention the Pfizer vaccine is given in 2 doses, the first one and then the second after 3 weeks. Several countries, and actually initially when I was not sure that we'll have enough vaccines, I was also trying to advocate the idea of maybe we don't have to give everything within the 3 weeks, but postpone it like the British did. They decided, for example, and I think other countries as well, maybe we should postpone the second dose and give more people the first dose. What actually is better? We couldn't test this because everybody in Israel got the second dose, or 99-point-something% got the second dose within 3 weeks. But we wanted to see what happens before we give, or just as we give the second dose. Will we see rate reduction? And we followed, on one hand, the total laboratory detected infections, and on the other, we looked for rate reduction in symptomatic infections, like what was done in the Pfizer clinical trial. And one thing we should mention when we are doing real-world not clinical trials, but vaccine effectiveness observational studies, we have a high potential for confounding, for biases, and that is typically the main issue. How do we know we're going to check vaccinated versus unvaccinated, and how do we know who gets vaccinated? It's not randomly. Maybe these are people who are at more risk. What are we looking at? Another issue is which outcomes should we look at? Do we want to look at asymptomatic infections? Can we? Who gets tested? What is asymptomatic? Is it just when they present as asymptomatic, or only if they never have any symptom? We know that many people have very mild symptoms. How do we define all of these? And then, of course, all the laboratory detected cases. And more easy is to check the symptomatic COVID-19 infections. And probably more precise is the COVID-related hospitalizations, probably more precise, the severe COVID-19 infections, and then finally the COVID-19 deaths. And we decided in our study to focus on the asymptomatic together with the symptomatic, and just check those because we're looking at healthcare workers, and they typically did not have the very severe infections because they are young and healthy mostly. Okay. Why is this not moving? Okay, now. Yeah. Okay, so what we did was look prospectively at 9,600 employees at the Sheba Medical Center, and we had a very intensive passive and active surveillance of symptoms and disease. Every day, people had to report of whether they had symptoms either they or anybody in their family. And we had a very easy testing, same-day testing. We could detect using also antigen testing in addition to PCR. So we could really detect the people very, very rapidly, immediately, pretty much. Once we detected anybody as a positive, we had a very thorough and immediate epidemiologic investigation for contact tracing, both looking back, looking forward, who might be a secondary case, and of course then both isolating if necessary and testing also all of those. And how do we actually assess them? Who are the vaccinated and unvaccinated? And what we did was look at each person and count the person days within each period. We divided all of the time a person spent between December 19 to January 24, in which phase was he? If he was unvaccinated, a person could be unvaccinated the whole month or 6 weeks we had here, or maybe he could, like myself, on the first day I got vaccinated, so immediately I left the first phase. I moved to being early post-vaccine 1 or post-dose 1 actually, and then after 14 days I moved to this phase, and then again, and on each day we assess all of those, whether he has symptoms, whether he's tested, and by that we can know whether people actually and divide the people to unvaccinated, early vaccinated disease, and so on. And if we look at the proportion of healthcare workers that were vaccinated, what we see here, the low or the light gray in the bottom are the people who are recovered. So they were not eligible to get the vaccine at that stage. Currently, actually, the policy has changed, and people who have recovered are eligible for 1 dose of the Pfizer vaccine. But at that stage, during that study, people were not eligible. And these are the people who had the first dose. So you see that very rapidly we achieved about 90% of people having, nearly 90% receiving 1 dose, and about 75 at this time of the study having already the second dose. So we could compare. All of this was days that we could compare as the denominator and then assess the infections. And just to again remind, this is when we started vaccinating, the rollout of vaccination, and this is exactly the time. So you see how many people got vaccinated while we had this surge right here, and it was still very high. So really people ran to get the vaccine, which was very helpful. And this is how, again, we measured them. So what are the results? Initially, we divided the unvaccinated people who got infected. So we had exposure days was 120,000 exposure days of being unvaccinated. And then among these, we had 89 cases of COVID, of laboratory positive. Then if we look at the vaccinated people who have at least 15 to 28 days, we had only 28 among the 88,000 days exposure days to the vaccine, to this vaccine. And this brings us to an effectiveness of 75% already for the first dose, actually. It's true that the second dose was given on the 21st day, but we don't believe that these first 7 days are actually effective. But in a minute, I'll show the other graph dividing this period further. If we look only at symptomatic COVID cases, we see an effectiveness of 85%. And this, I think, is really important data for countries that are not giving immediately the second dose. If we divide this further, we can see that after 15 to 21 days, really before, you have about 65% effectiveness, and then it rises. It still rises, I believe, before we have the effect of the second dose, but just after it's given. If we look at symptomatic disease, it's even higher. So the conclusions from this part of the study were that significant early reductions in SARS-CoV infection and symptomatic COVID rates follow the first dose of the vaccine already. And this may provide support for countries with vaccine shortage to delay the second dose, to allow a higher population coverage. Again, not saying that this is better than giving the second dose immediately, but just that from the first dose, you already have an effect. And again, we should, of course, be careful and say that long-term effectiveness studies of a single dose are, of course, needed. And I think we have them now, at least to some degree, from England. And obviously, it's better to get the second dose, and you're much more protected when you get 2 doses. But I think this was very encouraging. This is a paper of the Ministry of Health in Israel by Haas et al. And this is very small. You can't really see it. But again, they're comparing unvaccinated to fully vaccinated. But I think the most important, and again, there are a lot of problems with potential misclassification of asymptomatic cases. So I'm not sure how much that is. Also, maybe a differential bias due to national testing policy. But I think most important, so here are the results, but I think this is a little bit too small, just to show you again that the effectiveness altogether, this is after the second dose, is very high. Okay, we have about 95% effectiveness for, again, I would mainly focus on the critical, severe, and the COVID-related hospitalizations and the COVID-related deaths, which I think is pretty much precise. While, again, as I said, maybe for the asymptomatic, it's less precise. Here, it's really amazing, and you see the high, at least as high as we saw with the clinical trials of Pfizer. But I think more interesting than that was looking at the different ages. And here what you see is, as I showed you for the Sheba healthcare workers, here what you can see, and maybe one of the initial or potential criticism was that maybe this decrease in Israel, the surge really went down. Maybe it's just because of the lockdown that took place at the same time. So maybe this is all not the effect of the vaccine. How much can you be sure that this is the effect of the vaccine? And I think that this part of the study really shows this nice. So these are, the graph here is all of the people in Israel who are over the age of 65. And as you can see, very rapidly, they got vaccinated, very high coverage, 80% within, a few week or two got vaccinated. And then you immediately start seeing the decrease in the surge. If we look at the same time at younger people, 16 to 24 years of age, and they are not vaccinated at this stage, you see that for them, the surge is still continuing. Okay, we have this bump here, and only when some degree here it's about 60% that we start really seeing this decrease. And that's, I think, very, very interesting. And you have the different age groups also here, really showing how the surge follows immediately the height of how many people, the proportion of vaccinated people, and really indicating that the reason that we succeeded with this very high surge was the vaccine, and probably if we didn't have it, it would have been much higher. I should probably mention that this surge actually which was so high, was with the Alpha variant, or it was called the British variant. At this stage, it was between 80 to 95% of all of the isolates that we had were of the Alpha variant of concern. Then another very large study is the New England study by Dagan et al. And it was done in Clalit, in one of the largest HMOs in Israel, which I think probably has something like 50% of the Israeli population. And their idea was a little bit different, which is interesting. The idea was to design an observational study that would emulate a targeted trial of the causal effect of the vaccine. So the idea was, let's try to mimic a randomized trial. And what they did was, from the first day of vaccination, from the rollout, for each newly vaccinated person, they matched a person who was unvaccinated, a control of the same age, same comorbidities, etc. And they ended the follow-up once the person had an outcome event, which was either death or having being COVID infected, or if the unvaccinated person got vaccinated, then again, for that matched pair, the study would end. So this is a really nice and interesting design. And the outcomes that they looked at were the laboratory detected SARS, symptomatic, hospitalized, severe, and COVID deaths. Again, difficult to say anything about asymptomatic cases, but for this is a very nice design. And their cohort is over 3 million Clalit members. The cohort included all of them above the age of 16, because at that stage, that was the eligible age for vaccination. And of these, over 1.5 million were vaccinated before February 1. They did this matching of 1-to-1 of vaccinated to unvaccinated. And what they see is really a very nice separation of the curves of the vaccinated and unvaccinated, and which is very similar to actually the clinical trial. And you can see that this is the number of risk days, and this is the incidence, which is, as you can see, much higher for the unvaccinated population. This is for symptomatic COVID. It's also true for hospitalizations and also for deaths, while there were not so many deaths. And this brought us to the second phase of the Sheba vaccine effectiveness study, which was focused mainly on infectivity. And one of the initial points was, okay, let's say, and you're telling us that this vaccine is very effective, that's great. What about, do we still need to be with masks? How effective is it on infectivity? Maybe I won't be I won't have disease, I won't be sick, but I still might be infective, and I might infect my children who are not vaccinated. I might infect my patients who maybe are immunosuppressed. What about that? And so our aim here in this second part was to look on one hand on the VE, the vaccine effectiveness, within 2 months from the second dose, in contrast to the first study, which was looking mainly on the first dose, and the vaccine effectiveness on infectivity. And the idea was that in order to achieve herd immunity, this depends on not just on the amount of disease, but on reduced SARS-CoV circulation. Two determinants of interrupting the transmission will be preventing infections, symptomatic and asymptomatic, and also reducing the viral shedding. So the methods here are actually similar. I'll run through this a little bit, but the outcomes are slightly different. One thing we looked at in the first 4 outcomes is looking at prevalence of infections. So looking only among those who had exposures and were tested. And we looked both at what was the prevalence of infection among, depending on the fact that the person was exposed, and also on the prevalence of infective infections, meaning that there was a high viral load, which we counted as when the CT value was less than 30. We also looked at the prevalence of never symptomatic, so not just people who presented as asymptomatic, but also if they stayed asymptomatic the whole time. The other part was looking at same outcomes as we did in the first part, which is symptomatic and infective symptomatic and all of the laboratory confirmed infections. And again, this is very similar, just the periods were slightly different. We had fully vaccinated people, those who were at least 11 days after the second vaccine, and partially vaccinated are people who were between them. And then we had an early phase, which we considered as not really even yet partially vaccinated. And if we look at the numbers, we see that unvaccinated people during this period, we had 163 unvaccinated people who got SARS-CoV, while for fully vaccinated, and as you understand, most of the people at this time were fully vaccinated, only 31. And we can look at the severity. So the severity altogether, even for the unvaccinated, only one patient we had who had a severe disease and required oxygen. All the others were either mild or even asymptomatic, but the rates of asymptomatic are higher among those who are fully vaccinated. And also interesting is the test indication. We see that among the unvaccinated, the indication for testing was slightly more for symptomatic, slightly less for just people coming because of exposure, while for fully vaccinated, we had 74% of people coming because of exposure, and only a minority because of symptoms. And if we look at the vaccine effectiveness, and I'm showing just part of the results, this is the prevalence of never symptomatic infections, people who were actually never symptomatic. This is the vaccine effectiveness is 72%. And if we look at those people who are also infectious because they have a low CT value, then we're talking about 83% effectiveness in preventing infectious, never symptomatic infections, which we would not detect if we would not do the very intensive testing. What about reducing incidence of symptomatic infections? We see here results which are relatively similar to what the MOH results are, the Pfizer results, and the Clalit results, all of them showing that the Pfizer vaccine is effective in about 90% for symptomatic cases. These are mild symptomatic. For hospitalized and for severe, as I showed you previously, it's even higher. It's about 97% or 95%. Now, another interesting result we have is that the vaccine effectiveness, the vaccine reduces infectivity. So if we look here at, and on the Y here, we see the CT values, meaning that the lower it is, the higher viral load there are. So we have much more virus among unvaccinated people, and we have much lower viral load among fully vaccinated people. And if you look at how many are symptomatic versus asymptomatic, again, here you see that more people are symptomatic rather than asymptomatic, and here you see very few people who are symptomatic. And again, I think this is a very encouraging and very important result. So the conclusions at for this were that the vaccine is moderately to highly effective in reducing infectivity, and this is achieved via preventing infection as well as through reducing the viral shedding. And vaccinated healthcare workers who treat vulnerable populations should still be tested following exposures and continue to use PE, mainly to protect their patients, because they might still be shedding viruses, despite the fact that it's much lower than unvaccinated people. And now the second part of the things that we wanted to test was immunogenicity. Is it, and of course, is it a correlate of protection? So one of the things we want to look at is the immunogenicity in real life. How do the antibodies respond to the vaccine? Both IgG and neutralizing antibodies, and look at the kinetics and look at the different populations. Does it matter at what age you are when you receive the vaccine? Does it matter your gender, comorbidities, etc.? And for this is actually an ongoing study with a 1-year follow-up. Right now, we're actually checking the 5th, or we're starting next week, the 6th month after the first person at Sheba got the vaccine. And I'll show you some very preliminary results that are even still unpublished. First, what is the design of the study? So we have in total 14,000 people working at Sheba, including both employees, students, volunteers, etc. We had, for 6,000 of them, we had a pre-vaccine serology because we very much encouraged people to go and do serology. And we had about 600 healthcare workers who were recovered. Mostly we saw this by a positive PCR, some just by serology. And for this follow-up study, we recruited nearly 5,000 people where we followed them initially at week 1, 2, 3, and up to 5th week after the first dose. So these are actually after also the second dose. And then these same people are actually, we call it month 0, which is during the month after the second dose, 2 weeks to 1 month after the second dose, and then 1 month, 2 months, 3 months after the second dose. And what we're checking are 2 things, the anti-S IgG, through the Vacuna kit, and also pseudovirus neutralizing antibody assay. And what do we see initially in the 5 initial weeks? We see that after 1 week, very few people actually have a detectable antibody result. After 2 weeks from the first dose, there's a big jump, and already 78% of the people who received it had a nice response of IgG. And this was maybe slightly higher after the 3rd week. But once you got the second dose, this again jumped much higher. And then we had very few people who did not develop antibody levels. Some had lower levels, but most of the people had a very, very high level of antibodies of IgG. If we look at neutralizing titer, this is very similar, and indeed there is a correlation between IgG and neutralizing, which is very high. You can see this here, very high correlation, meaning that probably IgG can be a good correlate to what's happening with the neutralizing antibodies. If we look at the different ages, we can see that the younger population has a much higher response, faster and higher, and the older population has a lower and a slightly slower response. Again, after the 2 doses, does this really matter? Maybe for the long run, we're not sure yet, but there is a very significant difference. Also, even for sex, again, this looks slight, but it's a very statistically significant difference between males and females. Males respond slightly less than females to the vaccine. We also have some other, and again, you can look at the paper. It's supposed to be out, I think, next week. And you can see there we have some more categories of different comorbidities, but just to look at how immunosuppressed healthcare workers had a much lower response. The group is small and immunosuppression is very variable. Of course, it obviously is different if you're talking about acute leukemia patient who's on treatment, or GVHD person versus somebody who had lymphoma a few years ago, but he's maybe still immunosuppressed. So this is very different, and diabetes as well. And again, you can look and see there are some other things. Now, I'll show again these still unpublished data on preliminary results of the phase 3, what's happening after 4 months. And what we can see is that there is obviously a very significant decrease, which seems to be here linear. And I can also say that there is, up to the 3 month, a very nice correlation with neutralizing antibodies, meaning that they also decrease. But again, what is the meaning? Will it at some point slow and stay above, this line, which I'm not sure how much biological meaning this has. This is just the cutoff that the company decided on. Is this really the important cutoff? We're not sure. What is happening with these people here that have a below cutoff now? Maybe they were higher here, but now they're having it lower. Does it really matter? Or maybe we have enough memory cells that once they'll be exposed again to the vaccine, to either to the vaccine or to the virus itself, maybe they'll immediately produce a lot of antibodies. So maybe this really doesn't matter at all. And of course, we still don't know that, and we're looking into this right now. And then last, of course, the major question is, what is the correlate of protection? How do we know that? And here, I'm unfortunately not yet able to share with you too much of the data, but this will also be within a few weeks out, and you can see it. And this is looking at breakthrough infections of vaccinated healthcare workers. And what we did here is we had 39 such people 3 months after the second dose. This is a very low rate, 39 out of, here it says 8,000, I think it's actually 12,000 people. So the rate is really very, very low. And what we did is matched controls to cases of people who were also vaccinated but did not get infected. And we matched it, first of all, by the interval from the test day, from the second dose to the test day, sex, age, comorbidities. And we see that these are pretty much similar, the two groups. And then when we compare them, we can see that they have, the cases have a lower pre-infection, or maybe better to call it peri-infection, antibody titers. This is looking at neutralizing titer. It was also less significant, but still significant for IgG. And the main issue here is that we can't say sort of what is the threshold. We can only say that there is a correlation, but not really what is the threshold. And maybe even more important is what we found here on the right, where we see that there is an obvious correlation with the neutralizing antibodies with the amount of the virus that we have. The lower the virus, or the higher the neutralizing antibodies, the lower viral load that we'll have. And if you have less neutralizing antibodies, you may get higher viral loads. And with this, I'm pretty much about to finish. Just again, concluding, the first phase was showing that the vaccine induces a robust and a rapid antibody response, that the antibodies correlate significantly with neutralizing titers, and that there are different responses in different populations. The second phase was to show that an antibody decay is observed with about a 5% decrease per month. But are the antibodies a good correlate of protection is still a question. And here, the last part was trying to define the correlates of protection, and mainly showing that the neutralizing antibodies do correlate with the susceptibility to and the infectivity of SARS-CoV, but a threshold titer, which is what we are really looking for, is yet to be defined. We could not find it, maybe because all of our infections were really mild infections. And anyway, we need probably a larger study to look at that. And with that, I'll finish and just acknowledge a lot of people who were involved in these several studies, the laboratory, the Gertner Institute, our colleagues from Harvard School of Public Health, Mark Lipschitz and Rebecca Kahn, and the Sheba management, who was really involved with this, and of course the IPC unit, the Infection Prevention Control Unit, which I head, and all of the members of the unit. And so I think we can stop this pandemic, and we really all need to get vaccinated. If you still didn't, go and get it if you just can. And with that, I'll stop sharing and take questions. Where do I do that?
Gili, thank you so much for your presentation. We received several questions. The first one is, Doctor, thanks for your excellent presentation. Do you think will be necessary to have a third dose or annually vaccination against SARS-CoV-2?
It's a very good question. I have to say that I'm not sure I have the answer. I have, my thoughts, but we need to really be careful with this virus. Every time we think we know something, then we understand we don't know anything. So I have a feeling that we will need a third dose during probably this coming winter. Maybe then we won't need it. I don't know if it, one theory is that maybe it's going to become something more like the endemic coronas and that we won't need the vaccine. I'm not sure, but I think right now we're still in the pandemic, and that's why I expect that this winter, it's not that the whole world is going to be already vaccinated with 2 doses. So I expect that countries that can afford it will get a third dose, but it's my hunch. I'm not sure yet.
The second question is, what is the experience of Israel with the Delta variant? I guess part is this week there was reported an outbreak in children. So I guess the question is because of that. Do you know how many were asymptomatic or with severe disease, or how is the presentation of this Delta variant in the general population?
Yes, so that's true. We have currently a small outbreak, or, I don't know, I hope it's small. Right now, it's still small, of the Delta variant. And it all came from a few people coming from abroad. And they were the source of then infecting whole schools. We had one school with 70 kids, 70 kids with this variant. Very rapidly from the time that the first person came from abroad, because we had like about 4 cases detected per day now for a few weeks. And then all of a sudden, now we get these above 100 cases per day. Most of them, at least those tested, were the Delta variant, spreading very, very rapidly mainly in schools, because there the population is unvaccinated, but of course also among vaccinated people. And I should say that among the kids, we have right now maybe 1 or 3. We have I got some different messages, so I'm not sure, cases of severe COVID in youngsters who are not vaccinated. Again, young people are typically not that ill. Among the vaccinated that we have right now, again, this is just the beginning, but only mild cases. I don't think, maybe we have 1 case of more severe, but it's really right now. Again, I don't think that this means that this is the Delta variant. I think that maybe this means how the Delta variant behaves in vaccinated populations. Okay, because remember, nearly 90% of people in Israel at the risky age groups are vaccinated. So, it's a different issue.
Doctor, this question is, what strategies Israel is implementing to expand vaccination to those people that have doubts or hesitant to vaccinate? I guess because in many countries, this is a real problem that they are facing. So do you have any ideas? Can you share with us some audacious strategies that Israel is implementing right now?
Yeah, so I'll say right now it's not so much of a deal, because already we did most of the work. But initially, of course, there was, this is a new vaccine, we don't want to take it, all of that. And I think we really had a lot of PR on why, on one hand. On the other, it was the surge. So people saw every day, a lot of people who are sick, some of them in the hospitals, a lot of PR on, what's happening in the hospitals at that stage. I think all of that helped. In the hospital, I can say that we held several Zoom meetings where myself and other experts would be available for any question. And there were a lot of questions. And we were, with a lot of patience, just answering another question and another question. What about pregnancy? Maybe in the future we want to be pregnant. Maybe it's dangerous. All of that, and just giving a lot of data on right now what's happening, how risky is the disease on the one hand, and the fact that we're learning more and more on how safe, or at least relatively safe, this vaccine is, and why this is the only thing that will stop the pandemic. And I think just a lot of that. Right now, I can say what we're doing with healthcare workers is that we are not allowing new healthcare workers who are unvaccinated into the hospital. And those who have been working for years or, for a long time, and they don't want to be vaccinated, we have, as I said, about maybe 3% like that. But in a hospital with 14,000 healthcare workers, it's still, we have around nearly 200. I think it's going down every day. But people who don't want to get vaccinated, they have to, first of all, at this time, get tested once a week. So for COVID, so for some people that really pushed them to go and get vaccinated. And others, if they still refuse, we had even one case who refused for testing, and he was moved out of the hospital. He had to stop his work.
Perfect. There is a comment. Thanks for the excellent talk. It is very promising, the data about infectiousness and its impact in those unvaccinated. There are many more comments. Thank you for this presentation. And it is it gives hope. I guess everyone is like, when we will be under control with this pandemic. Doctor, I have two questions. One related to ethical issues. I guess during this pandemic, there are many ethical questioning related to data sharing, or why to request people or workers to get vaccinated. I think your results speak by themselves. What are your thoughts about this? How to manage these ethical issues? That is the first one. And the second one is, we already. So go ahead. I will ask the second one later.
Okay. So, I think you said it. It's really a big issue. And during the whole pandemic, it was, every day we had to put people in isolation. That's, is this ethical? We close them in their house. What do we do with their children? At some point, we put them in hostels in order to not infect their, a pandemic is really a tough time. And for that reason, I at least really pushed for that. Once we're not in such a dangerous point, and we are not right now in Israel, to really lift everything and not push people into, you have to be isolated, or you have to just go and check yourself, test yourself, be responsible, and, to really leave the, I don't know if unethical, but at least the very, how would I say, points where you tell people what to do, which is, again, maybe unethical. Leave that only for the time of a very severe pandemic. And once it's not as that bad, then, lift a little bit. And again, with healthcare workers, I think it's slightly different story, because we are treating whoever becomes a healthcare worker, whether a physician or a nurse, and, has to, is taking on himself that he wants to treat other people, and some of them are vulnerable, and we have to do several things. We have to wash our hands, even if we don't like it, and we have to also take vaccines, because that's the only way we can save others. So, if somebody really doesn't want, at least go test once a week. But for those people who really didn't want, and again, I think we had one in the hospital, they were thrown out of work, which is really horrible, but yeah.
Perfect. And the second question is related, this is more hypothetical. What are your thoughts about variants of concern? Israel is already with what we call herd immunity because of the vaccination that it was implemented. But what are your thoughts about the variants of concern in the future? More or more severe or more transmissible? What are your thoughts about that?
Yeah, obviously that's really the main concern. I think if you look at it globally, these variants of concern, because we already see that the Delta variant is obviously more transmissible than the Alpha variant. I think it's pretty clear by now. About pathogenicity or how severe disease, I'm not sure we have data on that. I don't know. And again, I don't think we will be able to learn about that on a vaccinated population, but only really on unvaccinated to see whether it causes a more severe infection. But obviously, these variants become more and more transmissible. And I think that's really that should push everybody to really go and get vaccinated.
Perfect. I will check if there are more questions here. We don't have any more questions. Dr. Gili, thank you so much for your time. I see that many people are very excited about what you share with us. I think it's promising. Stimulates that people go and get vaccinated. I just want you a final thought. This is not for healthcare workers. This is for general community. There are tons of fake news about vaccines, all sorts of conspiracy theories. So what are your final thoughts, or what would you say to the community in general that are not experts in vaccines or infectious diseases to motivate them to take the vaccine, to get the vaccine?
Yeah, I think, again, that's the most, as you say, the most difficult thing of how do you really convince the people. And I think it's really putting all of these things together. First of all, go and say, I did it, give. That's why, I don't know if you saw the last slide, is pictures I had on my, our first I will go vaccinated before the vaccine was there. Then I changed it to I got vaccinated, and, and then pictures of me getting the vaccine. And of course, explaining and giving all of the information. And, there will be opponents, but I think that for most of the general population, we just have to do the work. And it was really tiring because it was day after day after day, really convincing people on TV, on the Zooms and whatever, go get vaccinated. That's the only way we can get out of this pandemic. Yeah.
Perfect. Dr. Gili, thank you so much for your time. Thanks for your generosity, sharing all your knowledge and results. Universidad Pontificia Bolivariana, thanks so much for sharing your knowledge with us.
Thank you.